Right now in the field of MPNs, there are a number of gaps in terms of the therapies that we have available for our patients. But also happily, there are a large number of potential new therapies that are being tested, as well as our understanding of disease biology may help us to be able to try to target newer therapies, particularly perhaps in particular patients, but also to think about how we might design a new therapy. So in terms of the newer therapies that are coming, thinking first about myelofibrosis, of course patients with myelofibrosis have got usually the most aggressive disease. We have a very useful drug, ruxolitinib, which works for many patients, but on average, duration of response is relatively short. Certainly in terms of the clinical trials, 3.2 years. In clinical practice, generally, it's probably longer for some patients, a bit shorter for others. And so we have a big gap. What can we do either to make the response to ruxolitinib better and longer? So there we're usually looking at what things can we add to ruxolitinib in order to make the patient have a better or a more durable response. So there are a number of different studies that are underway looking at that. For example, adding something simple like a drug we would routinely have on the shelf to improve the hemoglobin or the platelet count like danazol, or adding a therapy that we would use for some patients like stem cell transplantation at the peak of the patient's response. But in terms of new therapies, then we're looking at adding drugs like navitoclax, the BET inhibitors, possibly also other agents such as MDM2 inhibitors, or drugs like luspatercept that was recently approved, for example, for beta thalassemia and is also being evaluated in MDS. We've also been testing that in patients with MF. So at the forthcoming ASH meeting, there'll be data for all of these combinations, including data for luspatercept in myelofibrosis. These agents are also potentially very exciting on their own, and as are the development of a number of other JAK inhibitors that we've discussed over several years now. They're still coming to the fore. For example, pacritinib, particularly for patients with marked thrombocytopenia, and momelotinib for anemic patients. Then when we look at the other myeloproliferative neoplasms, we see that for patients with polycythemia, we've recently had the approval of a novel formulation of interferon, which looks very well tolerated, which paves the way, perhaps for better, longer remissions for patients. But there are other agents also being tested in that domain, such as, again, the MDM2 inhibitors targeting P53 pathway. There are 2 drugs, one from Roche, one from Kartos, looking at that. But then also there's a re-evaluation of histone deacetylase inhibitors, particularly givinostat. For patients with ET, it's been a long time since we had a new drug. In the UK, we tested this ruxolitinib in the MAGIC study, which showed equivalence, but not really being superior for those patients who are resistant to standard therapies. And it's really heartening to find that some of the drugs, such as the LSD1 inhibitor, IMG7289 from Imago, or also the Constellation BET inhibitor, CPI610, are also potentially going to be tested in 2020 for patients with ET. So there's a lot of different therapies. But I would also say that we're also looking as a field to ask which patients do we know that have a really good prognosis using molecular markers that we don't need to treat. So we're focusing on intensifying for patients with high risk, but de-escalating for patients with low risk. So we've heard in the last year that patients who look like they have ET, but who lack a driver mutation or any other non-canonical mutation, those patients actually have a fantastic prognosis and are at very low risk of thrombosis. So in the field, we're now thinking, should we de-escalate care and not offer those patients the therapy?